extend my deepest gratitude to Dr. Claudius Berenga, to Colin Madembo for making this collaboration happen, and I'm being Society of Fetal Medicine India. We are extremely grateful uh, to be starting this collaboration with India and Zimbabwe for more academic benefits of our communities. So, with previous lecture of Dr. Verenga, he showed you the inverted pyramid. And I think that's the best way to begin my talk with, where we emphasize the 11 to 14 week scan as the most important scan in pregnancy. In fact, in India, we are now shifting the entire focus on the 11 to 14 week scan. But of course, we talk about 11 to 14 weeks in terms of nuchal translucency, but today's talk is entirely based on the basic morphological structure of the fetus. And that's the reason I wanted to emphasize the paradigm shift of picking up anomalies from 18 to 20 to now 11 to 14 weeks as a major anatomy scan. And we have to understand that we can pick up most of the anomalies even at this point in time, mainly because we have transvaginal transducers, which are phenomenal in resolution. And more importantly, you can pick up head anomalies pretty early on. Even by 10 weeks, you can pick up an anencephaly. And the advantages are distinct. We can offer early counseling, we can do genetic tests, and we can avoid a late termination of pregnancy. So though we talk about 11 to 13 weeks, 6 days, I personally prefer to do it at 12 weeks, 5 days, simply because it's a balance between penetration and better resolution. We also understand that transvaginal yields you better resolution, especially when you have dealing with high BMI patients. It gives you a far better resolution of the anatomy as compared to a transabdominal. So closer to 13 weeks and transvaginal is a better combination when you want to looking at anatomy. And like the second trimester scan, we look at the entire structure of the fetus, right from the head to toe, starting from the skull, the brain, the face, the orbits. We do the spine evaluation. Heart, we take two views, the forechamber and the outflows. We also look at the tricuspid rigors as soft markers, and we look at the diaphragm, we look at stomach, the unibladder cord insertion, and the limbs. And this is the best time to look at all three segments of all four limbs, because that's the best time to even count fingers at this stage, because they're best seen right now. Second trimester, it might get difficult when the limb goes under the body, but this is the time when you can look at the limbs very, very clearly. We look at the umbilical arteries and wind up with preeclampsia screening. Cannot emphasize the need to do the CRL, the right CRL, as you laid out by the Fetal Medicine Foundation, requires your CRL in a very specific protocol, because your NT and IT values depend on your CRL. And I'm going to discuss only the structural anomalies. I will leave the NT and chromosomal part apart in this scan. So when I talk about 11 to 14 weeks, I can divide them into three distinct groups. One, which were always detectable, and they were gross anomalies that you really cannot miss. They are distinct anomalies which can easily be picked up. There are certain anomalies like in the blue box which are not yet evolved, because the structures are not yet formed, like the corpus callosum, the cerebellum. Progressive disorders like bowel dilatation, bowel atresia, microcephaly will all be picked up in the later half of the trimesters and later half of the pregnancy. But we have the potential to pick up open spina bifida. We have a potential to pick up very common cardiac anomalies in the 11 to 14 weeks period, and that is what I would want to emphasize. So beginning from the CNS, we talk about open neural tube defect as a major development since Professor Rabiu and Professor Kipros described the intracranial translucency way back in the late 90s. That's when we started looking for the choroid plexus or signs of open spina neural tube defect in axial as well as in sagittal view. So we look at the choroid plexus, The choroid plexus forms the major component of the supratentorial compartment, but we always have some amount of fluid surrounding it. The moment you have a dry choroid plexus there without any fluid, we suspect open neural tube defect. We suspect open neural tube defect when the entire midbrain and brainstem herniates into the posterior fossa. The entire emphasis is basically to identify these two translucencies, the cisterna magna and the intracranial translucency, which is divided by the echogenic choroid bar or the echogenic choroid plexus of the fourth ventricle. So in open neural tube defects, the brainstem herniates back because of decreased pressure and the communication between the spinal canal and the amniotic fluid. And that's the reason you have a herniation which sort of obliterates the two cystic spaces. And that's the first sign of an open neural tube defect. If you look at the midline, if you look at the NT image, we can identify the thalami midbrain brainstem. And this is what moves posteriorly, and that's how you can identify it distinctly as a good landmark to exclude most of the open neural tube defects. And like NT, the intracranial translucency also increases with the CRL. So in an open neural tube defect, because the brainstem herniates back, it obliterates the IT, and that's the first sign that we can subjectively say that there is an open neural tube defect. But you also have ratios where the brainstem, because it is moving posteriorly, it gets thickened and it gets closer to the occipital bone. So the distance between the brainstem and the occipital bone decreases. And there are ratios which can objectively classify them as an open neural tube defect. Also, the translation between the cerebral peduncles and the thalami are divergent. When there is an open neural tube defect, the entire complex moves posteriorly and you have more or less parallel translation between the two. So if you look at this image, you see that the aqueduct of Sylvius, the cerebral peduncles have moved back, and you have a small cervicodorsal meningocele. Another example where we have the brainstem which is thickened, the IT is obliterated, and you find that there is a small neural tube defect in the lower spine. So whenever you have suspecting an open neural tube defect, we prefer a transvaginal scan because an open neural tube defect at this time is extremely small and is best visualized when you actually do a transvaginal study. Another example with the diastematomyelia on transvaginal scan at 13 weeks demonstrates an open neural tube defect with an absent NT. So we objectively classify the brainstem thickness to the brainstem occipital bone ratio. And if it is more than one, it is definitely an open neural tube defect. So make an extra effort to look at the lower spine. We also have this crash sign where because the entire brainstem is herniating back. If you draw a line along the upper edge of the maxilla, the 2/3 of the brainstem will lie above the line. But in an open neural tube defect, the entire brainstem will herniate down, and it will be just about a half of just about a portion of the brainstem will lie above this line. You can identify major anomalies like this hemimegalencephaly, which is quite evident in the form of a dilated ventricle. And if you look at the FARCS is abnormally pushed to the other side on the contralateral side, a very early case of hemimegalencephaly at 13 weeks. When you see a posterior fossa cyst, we look at the choroid bar, and now we can determine, depending on the direction at which it is displaced, we can place it as a Simple's Blake's spouse or a Dante Walker. But of course, we can follow them up at 18 weeks when the vermis is formed, and you can accurately characterize them. Ganglionic eminence cysts are precursors of neural migration anomalies, and they lie anteriorly. So you have to remember the choroid plexus never comes anterior to the foramen of Monro. When you see cystic lesions anteriorly, you have to think of a ganglionic eminence cyst and follow these patients up in the terms of neuronal migration disorders. If you look at this, you see a saddling monoventricle, you have uncleaved thalami, you have hypotelorism, all in all classic signs of alobar holoprosencephaly as a dysmorphic facial feces. and this is very classical trisomy 13. We can even identify the midline abnormalities in the form of midbrain to falx diameter, where we have in a normal patient, the falx is much longer than the height of the midbrain. But in the patients where the midline is absent, the midbrain sort of elongates. And when it elongates, the midbrain is taller than the distance from the overlying skull wall. And that's the midbrain to falx diameter objective criteria to say that there is an absent midline structures. Of course, you can visually see that the falx is absent, and in the midbrain, in the middle of the sagittal section, you can actually see the choroid plexus of the ventricle, suggesting that this is a sort of holoprosencephaly. Acrania, exencephaly, and anencephaly and as a sequence, the acrania talks about an absent skull vault and the brain is exposed to the amniotic fluid. Once that brain becomes deformed, it is called exencephaly. And when you have a brain which is absolutely absent, there is no brain there, an absent skull wall, this is called anencephaly, the last piece of the spectrum. And when anencephaly is associated with spinal abnormalities, we use the term craniorachisis. So it's all about terminologies that we want to use. Acrania, exencephaly, anencephaly, and anencephaly with spinal defect is craniorachisis. Encephalocele entails herniation of meninges to even any part of the brain. You can see the brainstem herniating from a posterior occipital defect there. You can even have just the meninges which are herniating out. All of this are a spectrum of encephaloceles that you will find there. In this patient, you have an occipital encapsulocele, and whenever we find an anomaly, we look for other anomalies, and we have a common AV valve there, a complete AVSD goes more associated anomalies, more likely of a genetic association. When you talk about face, we look at this microphthalmia, we have echogenic kidneys, we have a flat faces, and we have an alobar holoprosencephaly, all in all fitting into trisomy 13 at 12 weeks, 4 days. In this patient, we have a flat profile. In fact, the facial profile is concave, the nasal bone is seen, and we suspected binder's facies at this point in time, followed up at 18 weeks, and it did show a mid-facial hypoplasia, describing it as binder syndrome. We, of course, look at the chondrodysplasia punctata to reconfirm, and we always suggest an amniocentesis because we know that trisomy 21 is an association apart from the blood disorders like vitamin K deficiency. We look at palate as a homogeneous, thick, echogenic structure there just below the nasal bone. If we have a defect in the palate, we are picking up clefting pretty early on. An absent mandibular gap is a sign of retrognathia. If you look at the premaxillary triangle view, you will see the ramus of the mandible on either side separated by a gap, and that's mandibular gap is a good sign. The moment you see that the mandibular gap is absent, that means your mandible is receding, and a receding mandible can be a retrognathia or even a micrognathia for that matter. So mandibular gap is a good thing to see. Absence of mandibular gap is a sign that there is retrognathia. You can pick up clefts by looking at the premaxillary triangle. You see that there's a defect there on the left side associated with clefting of the lip and a very classical cleft lip and palate at 11 to 14 weeks. Anencephaly is a star-gazing fetus. It is likely a cervical anomalies. It can have a plain anencephaly, or it can be associated with encephalocele, like you see here that the entire brainstem herniates from a posterior encapsulocele, and you have a star-gazing fetus there. Thick nuchal fold is a thick nuchal fold irrespective of whether it envelops the neck or it envelops the fetus. It's a strong marker that we can evaluate these patients for chromosomal anomalies. It can be 18, it can be Turner's, very commonly Turner's. The thicker it is, very likely to be Turner's. When it is associated with other structural anomalies, we think of trisomy 18 as well. We can pick up hernias even at 14 weeks just by the location of the stomach pushing the heart to one side. That you can easily say that this is a left-sided hernia. We can even see the upturned superior mesenteric artery sign in cases where the small bowel is going into the thorax. The only problem that is that we cannot uh, prognosticate that because we use the lung to head ratios and the observed to expected lung to head ratios only beyond 16 weeks. We cannot use them before 16 weeks, but we can definitely prognosticate depending on the mediastinal shape, presence of eye drops, and chromosomal associations. This was a very early case of lung hypoplasia where we picked it up because the heart was entirely into one hemithorax. We could not see the lung on the other side. Heart anomalies are easy to see when you take the inflows. Normally, we would expect both inflows are parallel and symmetrical. If you don't see one inflow at all, we know that this is a right heart hypoplasia. In the outflows, we look at the ball and the stick appearance. If we don't see the ball and the stick appearance, we're dealing with a unilateral outflow anomaly. So we are now looking at AVSDs, which are associated with downs, but you can have a myriad of combinations, overriding of aortas, single outflows, TOF, all can be easily picked up. Even ASA can be picked up at 12 to 14, and we can suggest genetic test accordingly. Ductus venosus has got the classical SD and the A wave. Whenever the A wave is reversed, we think that this is associated with a soft markers of Down syndrome, or there could be a cardiac defects. And when the ductus venosus is absent, there are two different routes for the umbilical venous return, extrahepatic and intrahepatic. They are associated with structural and chromosomal anomalies. But if you have a thick NT and an absent DV, there's a 40% chance of chromosomal anomalies. But in most fetus where the NT is normal, isolated ductus agenesis will not make any difference to the outcome. You just have to ensure that the portal system is well and good. Physiological herniation ends by 12 weeks. So if you see anything beyond 12 weeks, which is more than 8 millimeter in height, which contains anything else than bowel, then you have to think of an omphalocele, which is associated with trisomy 18 mostly. You see that it's covered with amniotic membrane and the cord inserts at the top of the defect. And by the look of it, I know that it is liver. I can prove that by switching on color and you depict vascularity going into it. We always advise genetic testing when you see that. On the contrary, when you see just a free-floating bowel in the amniotic fluid, by paramedian defect, that's the gastrocytosis, no genetic association. If the bowel is good, you have a good outcome. If the bowel gets obstructed, then it will require a resection anastomosis and a guarded prognosis. Amniotic band sequence is separation of amnion and the sticky sites touching the fetus, causing major disruptive anomalies. Now, the major problem with amniotic band at this gestation is that they are very thin and they are quite disruptive and the fetus is small. So at this gestation, when you see amniotic bands, it generally causes gross disruptive anomalies of the fetus versus when you see them in the third trimester, it can just envelop one part, but at this gestation, it actually completely distorts the entire fetus. A close differential of amniotic band is a limb body wall complex. The only differentiating feature here is that in limb body wall complex is characterized by the absent umbilical cord or a very short umbilical cord. And that's the reason you will find that the fetus is stuck to the placenta with major kyphoscoliotic and limb anomalies. And that's a very good differential that you will use between the two. Pentalogy of Cantrell is when everything is open from the xiphisternum to the omphalocele. You have the heart beating in the amniotic fluid. That start from ectopia cordis right up to the omphalocele. It comprises a major structural anomalies. When you have a bladder which is more than 7 millimeters, it's called megacystis. So if it is between 7 and 15, and if you have excluded anomalies, these have generally good outcomes. But if they are more than 15, even after you have excluded anomalies, they generally land up with lower urinary tract obstruction. So watch out for bladder and watch out for associated anomalies. Then you need to do a genetic testing. And sometimes you can have associated anomalies, like here you have a DV, umbilical vein directly going into the right atrium. You can identify bladder outlet obstructions. You can identify a megacystis in the form of a prune belly syndrome, where the abdominal wall is lax and therefore the bladder occupies the entire abdomen. As you can see there, that's a classical prune belly. We do look at the kidneys, especially when you do a transvaginal scan, and you can pick up renal anomalies, suspect them, and then, of course, confirm that in 18 weeks. A single umbilical artery in isolation, we generally do not give much significance, but we have to ensure that a single umbilical artery has got a cardiac association, a renal association, and 42% of these fetus can have a third trimester growth restriction. As I said, this is the best time to look for skeletal dysplasias. This is the best time to look for ribs, hypomineralization, fractures. And remember, the golden rule is the earlier you pick up dysplasia, the worse is the prognosis. So when you pick them early, you will find that these are usually lethal. You can even have radial ray defects where we have an absent radius, an ulnar, and a radial deviation of the wrist with an absent thumb. All of this can be picked up. In this patient, we just have the hand which is articulating directly with the shoulder. There is no arm, there is no forearm, and you can see the arm, and you can pick this up at 11 to 14, terminate there and there. You can see bilateral talipus here with an abnormal curvature of the thumb. We did a whole exome sequencing, but you can pick up such anomalies. And I said this is the best time to count fingers. We can easily pick up polydactyly syndromes, even for that matter, arthrogryposis. You can see this thickening. There's a persistent flexion of the elbow and persistent curvature abnormality at the knee joint with an absent movement, the classical arthrogryposis, which is seen at 12 to 13 weeks. And look at that abnormality, which is so distinctly seen on 3D. This is a type D sirenomelia where we both lower limbs, the soft tissues are combined. You see only one sheen bones, and a classical mermaid's feet or sirenomelia, again picked up at 12 to 13 weeks. Remember, twins, well, you need to understand the chorionicity. The entire emphasis should be on chorionicity. Identifying conjoined twins is now getting rarer and rarer, but you can, once you see them, the diagnosis is quite obvious. What is most important is to identify chorionicity and chorionicity related complications. Like you have this trap sequence where you know that the trap needs to be reduced, because the higher the volume of the trap, the more it will cause effect on the normal baby. So we need to know RFA ablation for the trap sequence. Therefore, we need to understand the chorionicity. When you have a discordant twins, you can selectively reduce an abnormal fetus in dichorionic gestation by introducing KCL in the heart. But when you have monochorionicity, you have to do either a radiofrequency ablation or a microwave ablation. So my take-home message is quite obvious. 11 to 14 weeks is a game changer in today's time, and every patient should be offered them in our community. The earlier the pickup, the better the workup and more genetic tests, and we have enough time to terminate the baby. There are guidelines, there's standardization, and therefore checklist is important. Gross obvious anomalies are very easy to counsel. Correlation with NT changes the prognosis of every anomaly that you pick up. Measure intracranial translucency. That way you will never miss an open neural tube defect. And we certainly in India believe that if you have not documented, you have not seen. So learn to document as much as possible. The bigger question here is, can an 11 to 14 weeks anatomy scan replace the mid-trimester anomaly scan? Definitely not, because we know there are so many structures that are seen much later beyond 18 weeks. Plus there are evolving anomalies which come up in the later trimester beyond the second trimester. But the good part of seeing anatomy at 11 to 14 weeks is that whenever you have in doubt, there's always a scope for follow-up, preferably once at 16 weeks or even later till 20 weeks. Thank you so much for the patient listening, and I really extend once again my deepest gratitude on behalf of Society of Medicine India to Dr. Madembo and Dr. Verenga. Thank you very much.